the pathophysiology of the myxomatous mitral valve disease and its implication on the renin-angiotensin-aldosterone system, or the RAAS. So as you can tell, we have at the studio an Italian foodie who prefers to act and an American athlete who prefers to think. A very complimentary welcome to both of you.
Thank you.
Thank you.
From the US, Dr. Darcy Aden, you're clinical professor of cardiology and chief medical officer of small animal hospitals at the University of Florida in the US.
Yes.
With clinical research focus being heart failure treatments and the RAAS. Mm-hmm. Good for us to have you with us.
Thank you.
And Dr. Luca Ferrazin, your cardiologist and director of the Specialist Veterinary Cardiology Consultancy in Southern England. You have founded this consultancy 15 years ago, after 10 years of teaching in Italy, in the UK, in the US, and today you're providing cardiology service in various referral institutions, offering telemedicine services and also postgraduate teaching.
That's great.
We're really very lucky to have two cardiologists to update our knowledge on this mitral valve disease. And let's start with you, Luca. Why, in dogs, is this mitral valve disease so important?
Well, it is important because it is the most common cardiac disease seen in this species. Probably 75% of all cardiovascular abnormalities seen in dogs. It affects primarily geriatric dogs, so older dogs, and is characterized by a slow progression, and we can consider it, at least at the beginning, as a relatively benign condition. However, approximately 30% of these affected dogs will progress in their disease, and they will develop congestive heart failure and eventually die because of mitral valve disease.
Are all dogs concerned, or is it more prevalent in certain dogs or breeds?
There is a prevalence in small breed dogs, in Cavalier King Charles Spaniels in particular. This seems to be a particularly predisposed breed. And very early clinical studies dating back in 1987, performed by my own cardiology mentor, Dr. Peter Dark, described the high percentage of Cavalier King Charles Spaniels that develop this disease at a very young age. And this may suggest a genetic predisposition of the disease. And we know that approximately 90% of these Cavalier King Charles Spaniels will develop mitral valve disease by the age of 10 years.
And when that happens, what anatomical changes do you observe accompanying this disease?
Well, the first changes are obviously changes that affect the mitral valve itself. The mitral valve leaflets, they become redundant, a little bit distorted and thickened. And because of this abnormal anatomy, there is also an abnormal function. The valve will start bowing towards the left atrium, and we call it mitral valve prolapse, and then eventually will stop, coalesce, and seal the communication between the left atrium and the left ventricle, causing what we call mitral regurgitation. Mitral regurgitation is accompanied by audible heart murmur, which is characteristic of this disease. And then, depending on the severity of the disease, which is the quantity of blood that flows back into the left atrium with each cardiac contraction, we can have additional anatomical changes, namely enlargement of the left ventricle and the left atrium.
So an enlargement of the heart.
Of the heart. We call it cardiomegaly.
Assuming that the heart grows, what happens then? What does it do?
Well, a very common consequence of this cardiac enlargement is the compression of the airways that are above the heart itself, primarily the trachea and the main stem bronchi. So this mechanical compression can trigger cough in some patients, which is described typically as a dry cough. Dog owners often describe it as a honking cough or the sound of a bone stuck in the throat, which is very, very typical. However, these are, as we know, these are mainly geriatric patients. So geriatric patients are more likely affected by concomitant conditions, and airway disease is particularly important. We have, for example, tracheal collapse, bronchomalacia, chronic inflammation of the airways, and they all contribute to cough in these patients. So the problem is that, unfortunately, there is a widespread assumption that if a dog has a mitral regurgitation with the associated heart murmur and cough, they are dogs in congestive heart failure. This is dangerously misleading because very often these dogs are treated immediately with diuretics well before they develop actually signs of congestive heart failure. And what we can see sometimes, they receive very high doses because of the very inconsistent clinical response to diuretics. And so we see also all the side effects of these high doses of diuretics like polyuria, polydipsia. We can have dehydration of the patient. And we can also see, obviously, electrolyte imbalance and ultimately a drop in blood pressure with potential damage to the kidneys. But we need to remember that as long as the left atrium dilates during the progression of the disease, the pressure inside will remain pretty much stable. So we do not have the onset of pulmonary edema until the pressure increases. And then obviously with the progression of the disease, there will be a reduction in the stroke volume, which obviously leads to a reduction of the cardiac output. And this can be sensed by certain organs in the body, primarily the baroreceptors that we see at the level of the aortic arch and the carotid arteries, as well as the system in the macula densa, juxtaglomerular system in the kidney. And this will trigger very important neuroendocrine changes.
Thank you, Luca. I'll turn to Darcy now. These very complex neuroendocrine responses, what are they? Can you help us to understand better? And also, how does their activation contribute to the progression of the disease and the development of congestive heart failure?
That's a great question, Vic. The kidneys and the heart work together to maintain balance of sodium and water regulation with the ultimate goal of maintaining cardiac output and blood pressure. So when there is cardiac disease present or a drop in cardiac output, there are a couple neuroendocrine hormone systems that are activated. The first one would be the sympathetic nervous system. On the image on the left, those are the systems that are going to promote the development of congestive heart failure. So the sympathetic nervous system is enacted quite quickly when there's a drop in cardiac output to cause vasoconstriction and an increase in heart rate to kind of normalize that. And the sympathetic nervous system is also one of the triggers, amongst others, for RAAS activation, the renin-angiotensin-aldosterone system. And this system ultimately tries to cause vasoconstriction and sodium and water retention to maintain and bring blood volume and blood pressure back to normal. And it does this through a couple of different effectors, but most of those effectors are enacted by activation of the angiotensin type 1 receptor that then causes sodium and water retention, vasoconstriction. But another important aspect is it stimulates aldosterone release from the adrenal glands, and that also causes sodium and water retention, but can mitigate or mediate fibrosis in the heart and the kidney that can cause disease progression. And then other effects of angiotensin II include non-osmotic release of ADH from the brain, and that causes more free water retention, which can contribute to volume overload for those patients. And this occurs locally as well as globally, and locally it's in the kidney. And there's a physiologic mechanism called tubuloglomerular feedback, where the nephron itself is able to sense the amount of salt needed and is able to increase salt retention and water retention to affect changes that are needed at the glomerulus level as far as glomerular perfusion and filtration.
So I guess the body can somewhat counteract or counterbalance these effects, but to a certain extent, correct?
Yes, and like most physiologic systems, there is a counterbalancing aspect to that, and that's shown in the other aspect of the image there. So there are factors that are activated along with RAAS activation through the RAAS cascade in particular that can counterbalance the maladaptive effects that we just talked about. And some of those include the natriuretic peptides, ANP and BMP, that are released with cardiac stretch, and they cause natriuresis and diuresis naturally and vasodilation. And then when there's RAAS activation, the angiotensin II that's produced can also bind to another receptor, the angiotensin type 2 receptor, that enacts the opposite actions of the angiotensin type 1 receptor, so vasodilation, sodium excretion, and diuresis. And so these actions can help to counterbalance it in the normal situation.
And why is it important, or how can this help us understand the potential medical interventions?
Yeah, well, when we have chronic progressive heart disease that is not being repaired, as is the case with chronic mitral valve disease, there's a constant stimulus for RAAS activation. And so the balance becomes dysregulated, and the imbalance favors the maladaptive effects. And so the counterbalancing effects can't undo the maladaptive effects. And so that really does contribute to disease progression of the patient.
Thank you so much, Darcy. I'm turning now back to Luca. Luca, what clinical signs can we observe, or should the general practitioner look out for during the RAAS activation and during the progression of the disease?
Yeah, we need to remember that these changes that Darcy just explained represent a good intention of the body to compensate for the failing heart. But unfortunately, the disease will eventually progress, and this will bring to structural changes that we call cardiac remodeling. So basically, the increased blood volume that has just been mentioned is responsible for an increased venous return and dilation of the left ventricular chamber. And we can recognize this quite easily with chest X-rays, or even better with an echocardiographic examination. And again, as long as these chambers keep dilating, is fine, because the blood pressure doesn't increase. But at one point, this chamber will reach or approach the point of maximal compliance. At that point, the pressure will increase. And because in diastole, the left ventricle communicates directly with the left atrium, then the pressure in the left atrium will also increase. And this is important because an increased pressure in the left atrium also causes an increased pressure in the pulmonary veins that are coming from the lungs with the nicely oxygenated blood. And so the pressure increases in the pulmonary veins will increase also in the pulmonary capillaries, and we can interpret this as a force that pushes water out of the vessels into the interstitial space and alveolar space, eventually causing what we call pulmonary edema, which is responsible for the classical signs of congestive heart failure, namely increased breathing rate or tachypnea, or a labor breathing called dyspnea. However, cardiac remodeling is not just an enlargement of the left ventricle, the left atrium. We need also to consider other mechanisms that are involved in this process, namely the death of myocardial cells or necrosis, which is followed by inflammation, fibrosis, and eventually oxidative stress. So all these are part of the cardiac remodeling.
Thank you so much. Now, let's maybe talk or turn to the stages and the progression of the disease. The American College of Veterinary Internal Medicine has these guidelines, the consensus guidelines for diagnosing and treating the mitral valve disease in dogs. Luca, perhaps you can walk us through the different stages of the disease as they have been defined.
Yeah, this is a very good system because in a way it reflects the natural history of the disease, the way the disease progresses in nature. So we move from one stage to another with time, and it's easy to remember because every single stage is named with the letter of the alphabet. So we start with letter A, so the stage A is actually not associated with the disease per se, because it means that the patient does not have mitral valve disease, but is a patient predisposed to mitral valve disease. So a small breed dog or a Cavalier King Charles Spaniels will be in class A since their birth pretty much. And that's important because the primary vet can monitor these patients over time with regular checks, and especially the annual vaccination is an excellent opportunity to auscultate the heart of these patients. And then when the murmur becomes audible, it means that that patient has moved to the next stage. Mm-hmm. So stage B1 is when we got mitral regurgitation. So blood now is flowing back into the left atrium. However, at the beginning, this is not accompanied by any structural change. So the shape and the size of the heart remains the same. So it's important because in stage A, in stage B1, we do not do any medical intervention at this stage at least. And we need to wait until the following stage, which is stage B2, when, as I explained earlier, the left ventricle and the left atrium eventually dilate. At that point, there are medical interventions that can delay the progression to the following stage, which is, again, following the alphabet, stage C. Stage C means that the patient is in congestive heart failure. So has developed signs of pulmonary edema, and that can be recognized with a variety of tests, but primarily with thoracic radiographs, and nowadays also with echocardiography. And at this point, medical intervention becomes a little bit more complex. We need additional medications, and primarily diuretics will represent the first-line treatment because we need to remove this water from the lungs.
And we'll be talking about that in a moment.
Yep.
If the dog survives through this stage and keeps on living, can the disease evolve further?
Yeah, that's a very good point, because yes, if they remain alive with the current medications that they receive, they may eventually enter a condition called refractory heart failure that we call a stage D. So refractory means that a dog was responding very well to medical management. At one point, this medical management is no longer satisfactory in terms of clinical response. And so additional interventions are needed. These dogs may require mechanical drainage of the fluid accumulated in the chest cavity or in the abdominal cavity. They may require antiarrhythmic therapy. They may require more frequent hospitalization, a diet, and so on. So to control especially the cardiac cachexia, which is a very common complication in the end stage of this disease. So basically, these dogs start losing weight, muscle mass, and obviously this requires additional interventions.
Yes, and we see the list on screen. Thank you, Luca. Now, Darcy, is there a justification based on these facts for inhibiting or modulating the RAAS system to slow the progression of heart disease, and how does it work?
Yes, definitely. Considering that chronic upregulation and dysregulation of the RAAS contributes to the disease progression that Luca just went through, there's definitely justification for trying to intervene medically to modulate that. And probably at this time would be a good time to talk about the RAAS cascade in a little bit more detail so that we can understand where we might intervene with medications.
Yes, please.
So on the screen, you'll see in a minute that the RAAS cascade starts with angiotensinogen. That is not a limiting factor. Angiotensinogen is produced by the liver constitutively, so it's always present in enough amounts. But it is converted to angiotensin 1 by the actions of renin. And renin is produced when we have sympathetic nervous system stimulation with heart disease, or when we have a salt restriction situation, or hypotension or hypovolemia. And in fact, some of the medications that we use to treat heart disease can also activate the RAAS, such as vasodilators and diuretics. So when renin is secreted through one of those stimuli, then it converts angiotensinogen into angiotensin 1. And this, while inactive, can then be acted upon by the angiotensin converting enzyme, which is also called ACE. ACE converts angiotensin 1 to angiotensin 2, which is one of the major effectors of the RAAS cascade. And so we've already talked about the RAAS, but angiotensin 2 binding to the AT1 receptor and causing vasoconstriction. It also causes volume retention through direct effects on the brain to increase thirst, to cause non-osmotic antidiuretic hormone secretion, and to cause salt avidity. So these patients really want to take in salt. It also has actions on the kidney to increase glomerular filtration by squeezing the efferent arteriole in the kidney and causing acidification of the urine, which can lead to metabolic alkalosis, which might contribute to diuretic resistance as well. And in addition to those effects that we've talked about, angiotensin 2 also causes generalized inflammation. It causes fibrosis to be laid down in the heart and in the kidneys, and can cause cardiac muscle growth. But probably one of the most important things that angiotensin 2 does is it stimulates aldosterone release from the adrenal gland. And aldosterone is another major effector. It causes cardiac fibrosis, causes sodium retention, water retention, and potassium excretion.
Thank you so much for this explanation, Darcy. Where exactly can you intervene with medicine?
Yeah, there's a number of places that we could intervene to modulate this system to downregulate the maladaptive effects and upregulate the the beneficial effects. But two of the most common places that we intervene medically would be with ACE inhibitors. And so if we can if we can block the effects of the ACE enzyme, we can decrease the formation of angiotensin II. And if we decrease the formation of angiotensin II, we decrease all of those effects that we just talked about, including the decreased production of aldosterone. Some of the less well-known things that ACE inhibitors also do is that they upregulate the beneficial aspect of the RAAS, the alternative RAAS that we talked about a little bit ago, and that is done through stabilizing the production, stabilizing angiotensin 1-7, which is a beneficial metabolite, keeping it from being broken down essentially, and reducing the breakdown of bradykinin, which also causes natriuresis, vasodilation, and diuresis. So it helps to increase the beneficial aspect too.
Based on what you just said, can we assume that ACE inhibitors are enough to slow the disease?
Oh, it's tempting to think that, because if you look at the cascade, if we interrupt the formation of angiotensin II, we should mitigate all those downstream effects and reduce them. However, we know from studies in people and studies in dogs that about 30 to 40% of the population still manage to produce aldosterone even though we adequately suppress with an ACE inhibitor. And that might be influenced by genetics or other pathways for aldosterone production. But we can't in our clinic look at a dog and know if it's one of those 30 to 40% of dogs that's going to experience this phenomenon of aldosterone breakthrough. And so it does make sense to cover those patients with an aldosterone receptor blocker, just in case they're one of those patients that's going to experience aldosterone breakthrough. The most common one we use for that is spironolactone.
All right, so really there is a reason to go for the multimodal approach.
Definitely.
To address this. Luca, is there a diagnostic test to quantify the RAS activation in a clinical setting?
It would be fantastic to have one. Unfortunately, in a clinical setting, this is very difficult. However, there are some indirect estimates that can be based on the history of the patient, the clinical signs, and some very basic laboratory tests that we can run in practice. Theoretically, with the activation of the sympathetic system and the production of angiotensin II, as is being clearly explained by Darcy, then we should expect to see an increase in blood pressure due to the peripheral vasoconstriction, so the increased vascular resistance. But this is not something we see very often in these patients. And the reason is that blood pressure is one of the best controlled parameters in the body, because there are some organs that depend on a critical blood pressure, and the heart is one of them, but also the brain, and to a certain extent the kidneys and the vasculature. So blood pressure is not an easy one. Similarly, the activation of and release of antidiuretic hormone or vasopressin we would expect to see an increase in thirst and salt avidity, which probably the dog is experiencing, but owners may not necessarily appreciate. But the increased sympathetic tone and also the activation on the RAAS system, because the two are continuously activating each other with a positive feedback system, we can have necrosis. So we got death of the cardiomyocytes, the cells of the myocardium. And this will trigger an inflammation followed by activation of fibroblasts and production of fibrous tissue. So we got the scarring of the myocardium. Scarring is an important mechanism of arrhythmias. And arrhythmias can be particularly dangerous, can also be a life-threatening situation, can represent a life-threatening situation. And we can also see some echocardiographic changes due to this fibrosis. And arrhythmias can also be caused by a reduction in potassium, which is another thing we can see in response to the activation of the RAAS system due to the increased production of aldosterone. So we got loss of potassium to retain sodium in the system in order to expand the plasma volume in the body. So that can be another cause of arrhythmias. However, when we intervene medically, especially with ACE inhibitors and spironolactone, we very often reestablish the normal value of potassium in the blood. And in certain dogs where they are particularly inappetent, they don't eat, so they don't reintake potassium, we can consider also potassium supplements that can be given orally.
And I understand, even though it's difficult to quantify RAAS activation, you have some ways of looking at it. Darcy, are there specific lab tests to confirm RAAS activation and to assess the effects of RAAS modulation?
Yes, there are. Historically, it's been quite challenging to assess the RAAS because the metabolites are unstable, and most of the tests we used to use were single tests, and we know this is a really complex system where analyzing one metabolite doesn't tell the whole story. But in recent years, a company called Adequant has developed an analysis technique that allows us to simultaneously look at all the metabolites in the whole cascade relative to each other in a single blood sample. So it's really kind of revolutionized how we assess this system, and we can appreciate from the schematic that's behind me that you can appreciate that there are multiple pathways for producing all the metabolites, and that's not uncommon in physiology that you would have different pathways to maintain some of these metabolites. And it's given us an appreciation of the relative balance between these. And this is an example of how the data might look, where we could say, oh, the red ones are the maladaptive ones, the green ones are ones that are counter-regulatory and beneficial. And we can also get a sense for the enzyme activity by looking at the ratio of certain metabolites to each other. For example, angiotensin 1 summed with angiotensin 2 is a pretty good estimate for renin activity. We can also directly measure aldosterone in the blood through a different technique, or we can measure it in the urine, which gives us more of a longer-term assessment, maybe over a couple hours or a day. So we can get an assessment of that too.
It all sounds like the RAAS is very complex as a system.
It is a very complex system, and we are learning more and more about it each day and each year. It's real. This new ability to assess the whole cascade has given us a growing and renewed interest in trying to understand all the different pathways, really so that we can intervene medically to try to shift the balance over to the beneficial side and away from the maladaptive side so that we can reduce disease progression and help the patients.
And thank you so much, Darcy and Luca, for sharing all of this with our general practitioners. Before you go, I propose that we play and we launch the first quiz. So for all of you behind your screens now, scan the code if you haven't done so, and you should be taken directly to a screen proposing the first poll. And the first question of the poll is, which of the following can be considered for a diagnosis of refractory heart failure? We just talked about it with Luca. You have you have 4 possible answers, and you can select several of them. Yes, persistent cough, renal dysfunction, number of hospitalizations, or significant arrhythmias. We'll see if you have been listening closely, but submit your answers and we will see. Okay, I see people are getting on board. I'll give you a few seconds to vote before we give you the right answer. So you can select more than one. All right. This is a very, very shared response. Pretty much all 4 responses have gotten some clicks. Luca, what's the correct answer?
Well, I can tell you what the wrong answer is, which is the first one. So persistent cough might be present in refractory failure, but it's certainly not a specific sign. All the others are the correct answers.
Very good. So the last 3. Now, what are the effects promoted by angiotensin 2? That's the second poll question. Go ahead and type in. You have, again, 4 possible options. The options are A, water retention, B, sodium retention, C, cardiac fibrosis, and D, vasodilation. What are the effects promoted by angiotensin 2? Go ahead and vote. And I'll just click away with you to see what you are all saying. All right, so many people are still voting. Give you a few seconds. Darcy, what is the correct answer?
Well, the first 3 are all correct. The incorrect answer is D. So it causes vasoconstriction, not vasodilation.
Very good. That was a tricky question. Thanks so much, Darcy, Luca. Again.